The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
It's Tuesday, and we are gathered for the next episode of TMD Demystified. I am Tony Urbanek. If you're new to the podcast, welcome. If you follow the podcasts along, this is podcast episode number 179. I usually try to record these every Tuesday. They parallel a blog that I write every Sunday. The blog is directed to patients. The episodes in the podcast are directed to professionals, primarily dentists, but they usually parallel in topic and description and purpose. So today's title, I think, is, again, very interesting title. I hope you find the rest of it interesting as we roll it out. Very appropriate, for sure. It comes via my associate in the practice who came to me and said, we had a patient recently that was a diagnostic problem, and I had to ask your help in it, and I think that it would be good if you could put together a episode about differential diagnosis. So today's title is When You Shouldn't Treat TMD Symptoms, When You Should Not Treat TMD Symptoms. And hopefully you can see the relationship between that title and differential diagnosis. So differential diagnosis is not something that is foreign to the dental establishment, the dental profession. It is a little more complicated in the medical profession because they have more access to physical and technical tests that have been worked out to help in the differential diagnosis between diseases. But in the case of TMD, again, fortunately, it's all pretty simple. It's all pretty simple and not complicated. But we had a patient just recently, and I think that if you treat TMD to any degree and of any level of interest, you're going to run into these patients of one variety or another. So let me paint the little history on this particular patient. Hopefully you'll find it interesting. My associate did a consultation with a roughly, it's probably 70-year-old female and her husband. Female's primary chief complaint was she couldn't open her mouth, couldn't chew, couldn't open her mouth. And he had really went into the depth of the consultation, but before it was over, he decided he ought to bring me into it. And we might talk about why he thought in a little bit, but he stepped into my office. He said, Tony, can you come down the hall and see this patient along with me? Because I think it's a little bit outside my arena, my wheelhouse. So I said, sure. So I went in and introduced myself and began gathering information. The information was pretty simple to gather. First of all, I clarified that this patient couldn't open beyond one finger breadth and had been that way for roughly about 6 months. She had come to our office, not on referral from another doctor, but out of Google, and found out that, Googled doctors who help people who can't open their mouth, I guess, and came into our office. And chief complaint was, I can't chew and I can't open very well. And went into the medical history and right off the bat, learned that this patient had had surgery 3 years prior for an oral cancer here in Nashville at Vanderbilt. I actually got the name of the surgeon. I know the surgeon personally. And patient had had a radical neck done along with her oral cancer surgery. I didn't have the operative note or the discharge summary or anything available to me, but I gathered from the patient and the husband who was at the room the general information that I needed about this. Examination of the x-ray showed evidence of temporomandibular joint damage. She had significant degenerative joint changes within the temporomandibular joint. Her joints were hot. They were painful when pressed on, which is certainly an indication that there was chronic inflammation within the joint. The x-ray was positive for long-term chronic inflammation. And her two symptoms that she presented with are certainly symptoms associated with temporomandibular joint disease. However, she did have a history of cancer, but on further investigation, claimed that after her cancer surgery, she was able to open fully. She was able to open fully, and by her history, the decrease in ability to open did not happen gradually, but it was all of a sudden, which again would be another indicator that it would be a disc problem. A sudden decrease in ability to open is certainly evidence of a dislocated disc. So there's a lot of information here leading to a temporomandibular joint issue, a temporomandibular joint problem. But on further delving into the history, even though the patient told me her inability to open came all of a sudden and only a short time, less than a month or three, actually, I think she said 3 weeks prior, she was able to open fully. I didn't necessarily, it isn't the patient was lying to me, but I didn't believe her history was accurate. She was an older patient. Her husband was an older patient. I sensed that she didn't pay much attention. Neither of them paid much attention to their medical care. They had not seen the surgeon who performed the surgery for a couple of years, which was a little, very unusual in my knowledge and my experience, because when performing that level of cancer surgery to the head and neck, it's appropriate to follow the patients along looking for recurrence. So to make a not too long story short, I did a little bit more physical examination. I examined the patient a little bit in more detail about pain in and around the coronoid processes. One other thing that I did feel was that there seemed to be some exposed bone up around the right coronoid process, exposed bone. It was hard to get my little finger in up the ramus to try to touch the tip of the coronoid process. But again, it was painful to touch the tip, which was an indicator of TMD. All patients with TMD have painful coronoid processes when you push on them. So another indicator could be TMD, but again, I felt what I felt without being able to look at it, some exposed bone. She had been through radiation therapy and chemotherapy both, and those were long finished, long completed. Bottom line is, my judgment was at that time that this was not TMD. Her inability to open was not TMD and was caused by either a recurrence of the cancer, or more likely, could be a recurrence, but more likely it was gradual scarring of the surgical areas that were performed 3 years prior. Now, and that is the reason that my associate asked me to see the patient, because he is not an oral and maxillofacial surgeon. He's a general dentist, and he knew that my experience as an oral maxillofacial surgery and doing cancer ablation and cancer reconstruction in and around the face and oral cavity was relatively important, and he was right. So I was able to make that judgment, and my recommendation was you have to go back and see the original cancer surgeon. He is responsible to follow you along, even though you hadn't seen him. And I'm sure it wasn't because they weren't asked to be followed along. So it's a good example, a very obvious example of why it is important to know when you shouldn't treat TMD symptoms. Now, that was a very obvious example, and I use it as an obvious example. There's some other examples that are not so obvious, but you as a treating physician, dentist, whether you be general dentist, orthodontist, or oral and maxillofacial surgeon, just because patients have one or more of the symptoms on the TMD symptom list, frequent or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, fullness in the ears, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Just because they have one or more of those symptoms does not mean they necessarily have TMD. So you have to be able to keep in mind the potential differential diagnosis of these symptoms. On the antithesis, though, of that in the medical community, our problem of the doctors treating TMD is our medical colleagues don't think of TMD in their differential diagnosis when they have patients with frequent or recurring headache, earache, jaw pain, neck pain, ringing in the ears, fullness in the ears, dizziness, upper back and shoulder pain, arm, hand, finger tingling and numbness. If they can't open their mouth, admittedly, they may think this is a jaw joint problem. They might think that. But the other symptoms, going to a PCP, a medical doctor, his first thought is not going to be TMD. But the doctor of dentistry of one kind or another needs to have in his mind a general perception of differential diagnosis so that he does not misdiagnose the problem like our medical colleagues constantly misdiagnose TMD. So I just thought I'd throw out a few discussions, a little bit of discussions about differential diagnosis and the common diseases that can be confused with TMD that actually are not TMD and need to be referred on to the appropriate doctor. One of the other things that I mentioned in previous episodes was my experience talking with a room full of 30 family practitioner MDs. This was a couple years ago. And ask the room their opinion, what they thought they would do if they were presented with a patient with acute and frequent and recurring severe headaches. And I said, what is the first thing that you would do, without giving them a list of options? I just said, what is the first thing that you would do? And basically 90% of the room agreed that the first thing they would do is they would send the patient out looking to get a MRI looking for brain tumors. Now, these are family practitioners, but the first thing they wanted to do was check out the head for brain tumors. And brain tumors are certainly present, but the incidence of brain tumors in comparison to TMD are extremely limited. And sending a patient out for an MRI, you just wasted, $2,000 or $3,000. Where you can examine a patient for TMD, if they have frequent or recurring headaches, all you have to do is put your fingers in the glenoid fossa, have them open widely, push hard, and have them bite rapidly. And if it hurts, the joint's inflamed, you've made your diagnosis, almost for sure. It gives an example of why medical doctors misdiagnose this all the time. They're looking for the worst, and they don't think of the simplicity of the number of headaches that are associated with temporomandibular joint disease. But on our side of it, on the dental side of it, you need to be able to be aware that don't think that all headaches are associated with TMD. And sooner or later, somebody's going to walk in your office or walk in another doctor's office with frequent or recurrent headaches that are actually brain tumors. So you want to modulate. The next point I want to make is you want to modulate the symptoms. Now, if For example, if the only symptom the patient has, you run down the symptom list that I've now reeled off twice in this episode, and they only have one symptom, which is headaches, that doesn't mean they have brain tumors. It means you need to be a little suspicious. This might be something else going on if they only have one symptom. On the other hand, and that is the reason you don't accept just the patient's history as to what their symptoms are. You allow the patient to give you their rendition of the symptoms, and you can list them in your mind as they go through. Here's what my symptoms are, doctor. It hurts my jaw every morning when I wake up, and I have headaches constantly, at least 2 or 3 times a week, and I got this neck pain. Well, if you have those 3 symptoms, you're adding to the number of red flags that would lean your differential diagnosis toward TMD. On the other hand, if the patient comes in and they say, I've been having acute headaches for the past month. Have you had headaches that go back any further? No, just the past month. And then you go down the potential symptom list and they have no other symptoms. I, as a double degree oral and maxillofacial surgeon, would be very suspicious that this might be another kind of headache, for example, possibly brain tumor. And if I thought a little further, I would not hesitate sending the patient out for an MRI or sending them back to their PCP or making a referral to a neurosurgeon if I was fairly convinced it might be something like a brain tumor. Point being, differential diagnosis is important, and you can't assume that it is just TMD. The fact that you not experienced with a routine set of patients who have these other symptoms, why? Believe me, the other PCP medical doctors are not necessarily that experienced either. If you have paid attention to your basic sciences and you learn a little bit about taking a history and general medical symptoms, I think a dentist is more than adequate able to differentially diagnose TMD versus some of these other things. Now, you can't nail down the diagnosis. I would not expect you to nail down a diagnosis of a brain tumor, but you can suspect it and one way or another run it down either to, a positive or a negative. The other thing is cancer, like the case I just gave you. This lady, we knew she had a prior cancer, but she looked okay. I saw no evidence on my physical examination. As much as I could examine her oral cavity, I saw no evidence of any other areas of mucosal damage or swelling. There were no positive nodes. I didn't see any other evidence of cancer. That is why I strongly suspect it was not a recurrence, but it was a gradual, which happens after certain parts of cancer oral and maxillofacial surgery. The scarring over time can scar down the muscles and the associated fascia that continues to scar down over time. I have seen this. That's why I was familiar with it. And without any further test, as the patient was sent out, my opinion was, of the two, was it a recurrent cancer or was it gradual scarring of the patient unable now to open only to 1 finger breadth? I would bet on it was the scarring problem, the gradual scarring down to 1 finger breadth of opening. But that hasn't been proven. That's my opinion at this time. So, but I've already observed in my career, after doing treating well over 4,000 people successfully and probably doing 5,000 or 6,000 consultations, I have noted 2 occult cancers that mimicked TMD symptoms. Occult cancers of the oral cavity, actually the pharynx, occult cancer of the pharynx causing the muscles to go into trismus, an inability to open, and some pain. one case I picked up immediately, knew that this was not TMD, and the other actually, I had to see the patient back a couple times. Actually, what happened in the other case I'm thinking about is I actually put the patient into a splint. It was a he had enough opening. He did have hot joints. He had several of the attributes and symptoms of TMD. So we made a splint for the patient, but he came back and he had no significant change. The results were not as expected. And we don't see patients who come back after 3 weeks, after 6 weeks with no significant improvement, decrease in their symptoms. That if they follow the protocol, that does not happen. So when I couldn't get the response I was expecting in this particular case, I investigated further and found that, yes, I did diagnose a occult cancer, meaning a cancer hiding in the posterior pharynx, sent that patient for further intervention. Wasn't happy that I missed it in the first place, but I did catch it in a relatively short period of time. So the point is, differential diagnosis, it is important to understand that you need to keep it in mind. Some of the other differential diagnoses you need to keep in mind that can mimic TMD symptoms is cervical discs. Now, it works both ways. I have seen patients who actually responded extremely well to TMD treatment, decrease inflammation in the joint by using the splint, the device and protocol, that had already had disc surgery because they had neck pain, which did not decrease their neck pain. But it can work the other way. You can have a neck problem or an upper back and upper shoulder problem that is related to a cervical disc displacement or nerve impingement that can be misdiagnosed as TMD. So again, to repeat myself, if you keep in mind the 10 primary symptoms, there are some secondary symptoms. We're going to go over one of the secondary symptoms here in just a moment, but you go over the 10 primary symptoms. The more of the 10 primary symptoms that are present, the more certain you may become that this is more toward TMD and not something else. Again, if the only symptom the patient has is upper shoulder or arm, finger tingling and numbness, no other symptoms present, you may think, well, this may be a disc problem, and send the patient on to an orthopedic surgeon or a neurosurgeon, both of them treating disc problems of the neck, and see what they have to say. And they may rule it in or they may rule it out. Don't be afraid to do that. You don't have to be a doctor to all portions of the body. You just have to be able to properly differentially diagnose. Rotator cuffs, so many people complain of upper back and shoulder pain, which can be confused with rotator cuff damage or bursitis. But again, if you have multiple symptoms, and most people do, most people who have TMD will not have just one symptom. They'll have, of the 10, they'll have 3, 4, 5, 6. It's not unusual for us to pick up in this practice people with all 10. That is not unusual. The majority of people have at least 4 or 5 of the 10. And so when you get someone with 4 or 5 of the 10 symptoms, you're leaning more toward, I feel pretty certain this may be TMD, and then you do the exam. And if they have hot joints, you've made the diagnosis. Is it possible they could have both at the same time, TMD and a disc displacement? Absolutely. Would it be likely? No, not too likely. In fact, very unlikely. But if you've done your due diligence and you document it in your chart, no one is going to help hold you responsible for making a misdiagnosis if the diagnosis you made makes some reasonable sense. And that, as I gave you an example before, and if you do not get the response you're expecting, then it's time to take a second look at it. And again, go through your differential and say, well, maybe this wasn't TMD. What could it be? So that's the nature of our medical science and using differential diagnosis. I just had a very interesting case about differential diagnosis, just came to my attention. It's been a year. A patient came into me and she had TMD symptoms, but she also, her big complaint was she had very swollen cheeks, and they were swollen. And of course, speaking of differential diagnosis, I looked her over very, very carefully for parotid tumors, for certainly any type of cancer. I saw nothing at all. She had full motion of the mandible, but she did have very swollen cheeks. And it's a good example. I'll tell on myself. I just learned, she called up our office. This was a year ago I did this examination. I treated her for TMD. Her TMD symptoms went away. Her swelling in her cheeks did not go away. And I missed the diagnosis of mononucleosis. And she had seen multiple doctors. I was not the only one that had missed this. But after a year of battling with why are my cheeks so swollen, someone, and I don't know who, because we just got the message that she called in, wanted to let me know because I was concerned about her. She knew I was concerned about her, but I had no answer. And I missed mononucleosis, which certainly can cause that amount of swelling of the parotids. Bad me. But it happens, it can happen, and it can happen to anybody. As I said, I overlooked 2 occult oral cancers. Carpal tunnel, that's another one. You know, a large portion of patients who have TMD complain of arm, hand, or finger tingling and numbness, because when the strap muscles on the side of the neck get the signal to tighten up, don't move the head, and they tighten up, they squeeze the brachial plexus, which causes arm, hand, finger tingling and numbness. It is a not too well known by the TMD gurus, but there are some of us in this part of the TMD service that are well aware, and certainly our network providers are aware because we teach it. Arm, hand, finger tingling and numbness is a valid symptom of TMD, but it can be confused with carpal tunnel syndrome. And I have had several patients who have had their carpal tunnel operated on when it turned out the carpal tunnel operation did not fix their numbness of their fingers, but when we made the inflammation in the joint go away by placing a patient in a disoccluding posterior device over a period of time protocol, their finger tingling and numbness went away, again, because of the squeezing of the brachial plexus up here at the level of the neck and the strap muscles and the scalene muscles. And the last thing I want to talk about today, and then we can wrap it up, and that is something that I am investigating now, and I'm not going to make any claims on it at all, but I have run across, out of the first 4,000 people, several. I probably missed some, but I have identified roughly 4 of patients that we treated for TMD whose claim that their visual disturbances also decreased with treatment of the chronic inflammation within the temporomandibular joint. So let me explain. It is well known, maybe not well known to you, to the listener, but well known in the headache differential diagnosis arena, that the primary differential diagnosis between all the other kind of headaches and migraine headaches are visual disturbances. In other words, if a patient comes into a medical doctor and says, I have these headaches that hurt so bad, all I can do is go to bed and sleep. And I also, when I have them, I know they're coming on because I start getting these visual disturbances. They can be disturbances of peripheral vision. They can be disturbances of blurred vision, of problems with the field of vision, but visual disturbances of many kinds. Well, I have now had 3 or 4 patients that I'm aware of, had one yesterday, who because I was following her along, she told me she had visual disturbances along with her other symptoms. And I said, I want to follow you very carefully, make sure you report to me how your visual disturbances are doing as your painful symptoms go down. And she reported to me yesterday that her visual disturbances had greatly improved. She described her problem as blurred vision. She described her problem as things that it kind of rapidly went blurry, described her episode at a stoplight where she literally could not see the stoplight all of a sudden. But that had cleared as her temporomandibular joint symptom, the other temporomandibular joint symptoms cleared. So the point being, I'm not claiming that migraine headaches that are associated with blurred vision are all associated with TMD. What I am claiming is that we've had several patients who were diagnosed with migraine headaches because they also had visual disturbances, where the visual disturbances decreased as the TMD symptoms decreased. And the purported mechanism, won't say this for sure, have not done the studies, have thought about it, investigated anatomically, physiologically, neurologically, though. There is no reason why the bleed over or spill over within the brainstem, which creates signals to the various muscles of mastication, various muscles of the neck, and various muscles of the upper shoulder girdle, not all at the same time, would not also be associated with stimulation of the ocular muscles, V3, V4, and V6, because of bleed over from the brainstem, because all of the nuclei of all of the cervical nerves are located within a very, very small area of the brain stem, which is about that long and about that big around. And all the nuclei of all of the cranial nerves are located within that area. And we know there is bleed over between the different nuclei within that brainstem. So sometimes the signal will signal one nucleus of one nerve, the fifth nerve, and it can bleed over into nuclei of other cranial nerves. Interesting. Just throw out that as an interesting fact, yet to be determined, definitely yet to be investigated, but that has been noted. That has been noted on several patients. So that's what I have to say about differential diagnosis. There's no clear-cut method to do it other than to collect your symptoms. The more symptoms you see associated with TMD, the more red flags, the more you should be suspicious of TMD. But don't forget that there are other things, there are other diseases that can mimic the symptoms of TMD that are standalone diseases that you don't need to overlook. But don't be afraid not to do a differential diagnosis, and do not be afraid to diagnose TMD, especially if they have multiple symptoms and they have hot joints. Actually, the definition of TMD should be changed to chronic inflammation within the joint. That's what it should be called. The long version of temporomandibular joint disorder should be called chronic inflammation within the temporomandibular joint. If you would like to find out more about how to treat TMD with a very simple oral device which separates the back teeth carefully, not allowing super eruption of the teeth according to a proper protocol, you can learn more about us at www.urbanektmj.com. If you'd like to talk to me, if you'd like to communicate with me, criticize what I have to say or teach, or just discuss, you're welcome to do that. I'm reachable at tony@tmjservices.net. Until next time, I look forward to your presence and learning as much as I can teach about TMD Demystified. I am Tony Urbanek.